I'm calling this the Culture Change Challenge, everyone, because we get a moment at the beginning here to maybe challenge ourselves all today. That's a big ask, everyone. And then I'll do more toward the end. And today I'd like to just draw attention to kind of a sad habit that takes place in this field of labeling people. And I don't know if you know that not doing this even landed in CMS regulation. This actually was put there in 2009 after we did a large symposium on culture change that same year, or actually 2008, but doesn't matter. It has remained there, which I'm glad to see with the reg changes of 2016. And so under resident rights, tag 550, in a section regarding respect and dignity, it actually says to avoid the use of labels. And they give two examples, feeders and walkers. And I would love to invite every one of you, ready? Every single one of you, to put a label in the chat that you've heard, or more than one, and then I'll bring it back up at the end. Thank you.
Great, thank you, Carmen. We'll keep an eye on those labels that show up in the chat box. Oh man, there's fun ones popping up already, and I know we can dive in and just talk about them. Here, I'll put mine in, which is more on like the emergency side. All right. Well, let's keep putting those into the chat box. So don't be shy with putting in your labels, and Carmen's going to keep note of those. And we'll turn it over to Dr. Caroline Stevens. Talk to us about mind mentation.
Great, thank you, Catherine. It's exciting to be here. You know, I was here just a few weeks ago talking about behavioral health care and resident-centered care. And now we're going to work on the mentation. Next slide. And I also wanted to kind of highlight a comment that Dr. Jurovich had mentioned last week with regards to the 4Ms and specifically mentation. And that was when they did some stakeholder groups on the age-friendly health system with the Indian Health Service. They really found that the use of mind was much more positive and less stigmatizing than mentation. So that's why I have mind mentation in here. So our goals for today, we have a lot to cover. Apply mind mentation assessment and management in the context of the geriatric 4Ms, prevent mentation problems in older adults, utilize evidence-based tools for assessing mind mentation, and using non-pharmacological and pharmacological interventions to address these mind mentation issues. Next slide, please. So let's start with a pretest. What are the goals of addressing mind mentation? Please select all that apply. Is it to support cognitive functioning, maximize independence and dignity, ensure everyone is prescribed a cognitive enhancing drug like Aricept, identify and treat 3Ds of aging, depression, dementia, and delirium, prevent the 3Ds, or all of the above? Let me know when we have a good response. Next slide. So I'd like to start with a case study, Mrs. Jones. She is a 78-year-old female with a past medical history significant from mild to moderate dementia, hypertension, COPD, diabetes, and a left bilateral, a left below the knee amputation. She's lived in the Shore Acres SNF community, and instead of saying she is a nursing home resident, she has lived in the community for 3 years, and she recently returned, not readmitted, but she recently returned to her community, status post 6-day hospitalization for pneumonia, including 2 days in the ICU. And I highlight the language because I too am also working on this, and I appreciate Carmen's keeping us all honest here. So Ms. Jones was previously able to roll her wheelchair around the facility, didn't catch that one, and was very engaged in activities. Now she seems withdrawn, spends most of her time in her bed sleeping, and she's not participating in activities. Her appetite is poor, and she's had a 5-pound weight loss since her readmission. She frequently falls asleep during meals, and the knock shift notes she's been up at night ×3, is restless, impulsively wanting to get out of bed without assistance. So what do you think's going on with Mrs. Jones? Next slide, please. There's another Zoom poll. A, she's depressed, but she cannot do what she once did and needs to be evaluated for an antidepressant. This is just sundowning and worsening of her dementia. She may be experiencing delirium and needs to be evaluated for potential medical issues. D, she's having a lot of phantom limb pain from her left BKA and needs more pain medication. E, she needs an appetite stimulant. Or F, all of the above. Okay, can you show me, do we have results from the Zoom poll?
We do. We have for the Mrs. Jones poll, we've got about 40%. Do you want me to go ahead and share those results?
And will it keep showing the feed as we're talking?
No, because I have to end the poll before I can share the results, unfortunately.
Okay.
Sorry.
Okay. No, that's fine. That's fine. Let me know when we're at least at 50% and then we can show it.
Sure.
All right. So we have a crowd that recognizes the need to evaluate for potential delirium. Okay, let's keep moving. So next slide, please. If we can put in the chat, what are the 3Ds of aging? Oh, and I just noticed all of the characterizations or labels, the screamer, the long-termer, the Houdini. So the 3Ds of aging are dementia, delirium, and depression. Yes. Next slide, please. So I like to refer to dementia more as chronic confusion, and that's to set it apart from delirium, which we'll get to in a moment, which is more of acute confusion. Next slide, please. So dementia is an umbrella term used to describe a set of symptoms that include changes in memory, perception, reasoning, attention and concentration, thinking, judgment, and language. And according to the DSM criteria, must be severe enough to interfere with a person's ability to function. And I like to emphasize, click please, that it is not a normal part of aging. We sometimes think that, oh, people are just getting old and senile, but dementia is actually a diagnosis and a syndrome that needs to be evaluated. Okay, next slide, please. Dementia, the number of individuals expected it's expected to triple from 5 million to nearly 15 million individuals in the next 25 years. It affects nearly 60% of persons living in nursing homes, and it's the #1 risk factor for developing delirium. And there's a high prevalence of BPSD, the behavioral psychological symptoms of dementia. And if you recall from our session a few weeks ago, we were trying to kind of change the language to think about them as behavioral expressions in dementia. Because about 78% of individuals living in nursing homes have these behavioral expressions. Next slide. And as we talked about a few weeks ago, there's several different factors that contribute to behavioral expressions, from the physical, emotional, or the environmental. Next slide, please. And again, as a recap from a few weeks ago, these behaviors are not problems, even though they present quote unquote management problems for staff. They represent unmet needs, and all behavior has meaning, and it's up to us to figure out what it means. Click, please. Great. Next slide, please. And I know many of you are already familiar with the BIMs that you do in the MDS for diagnosing dementia. And while it's technically not used to diagnose, it's a good screener. It helps to identify changes in cognition over time and can certainly be a trigger for more comprehensive evaluations. And the scoring helps you kind of figure out where this individual is, and certainly can be a helpful tool if you're starting any particular types of medications or just changing cognition, monitoring changes in cognition over time. Next slide, please. And there's also many different other dementia assessment tools, from the mini mental status exam. It's kind of fallen a little bit out of favor, even though it had been the gold standard for many years. They started charging for the use of it, and there were also some educational biases, and it didn't necessarily capture executive functioning. But it's still a really helpful way of communicating. When someone says, oh, they have a mini mental of 15, you have a pretty good idea of where they are on the dementia spectrum. One that's become increasingly more commonly used is the MoCA. There's also the mini-cog. And then the last two are more for kind of rating and staging dementia. And I put the clock test there because that's sometimes, aside from the fact that they're incredibly fascinating in terms of how individuals complete them, but also just helping you understand kind of the executive functioning, because it really takes a fair amount of ability to plan, organize, sequence, putting the numbers in the clock and drawing them out. So that's sometimes kind of a quick down and dirty way to assess whether you need to look further. Next slide, please. But I think what's important to remember is that there's many different comprehensive interprofessional assessments that you're already doing. And it's important to use these not only to identify, click please, dementia-related symptoms, but more importantly, to identify preserved cognitive abilities that can be supported through modification of the environment, task adaptations, use of communication and cueing strategies that facilitate engagement and participation, and also facilitating smooth care transitions across settings, because it's important to be able to communicate a person's baseline mentation when you're sending an individual out to the emergency room. So the emergency room also has a sense of where is this person along their cognitive trajectory, and does this represent an acute change, or is this more of a chronic progressive neurodegenerative illness like dementia? Because understanding an individual's specific cognitive challenges and remaining abilities is really essential to supporting person-centered care and what matters to each individual. Next slide. And delirium, on the other hand, is acute confusion, or what I like to refer to as acute brain failure. And again, click, it's not normal aging. Just because someone is old doesn't mean that their confusion is normal. Next slide, please. Delirium is a syndrome characterized by disturbed attention and orientation that develops acutely and fluctuates. Two key parameters there. And it's accompanied by cognitive deficits such as disturbances in memory, language, perception, or consciousness. And again, I like to refer to it as acute brain failure. It's a medical emergency, and there's usually something going on to help that we have to identify, what's the underlying etiology. And it used to be that delirium was considered a reversible form of confusion, and they're now recognizing that folks that have had an episode of delirium and might not have any dementia do have a higher rate of developing dementia down the road. Next slide, please. So why is it significant? Delirium is significant because it is associated with increased morbidity and mortality, higher rates of complications and prolonged hospital stays, delayed rehabilitation, increased rehospitalizations. So that's a really important parameter for those that are trying to work on the 30-day rehospitalization metrics. It also results in a lot of higher rates of nursing home placement. And this is an old figure in terms of the expenses, but it exceeds $4 billion. So it's very costly and a source of significant morbidity and mortality. Next slide, please. But unfortunately, it's poorly recognized and managed. Again, it's overlooked, misdiagnosed, misattributed to normal aging. 30 to 50% isn't even recognized by staff. And in one nursing home study, 88% of patients with delirium superimposed on dementia went unrecognized. And these are the folks that are at the highest risk for bad outcomes. Next slide, please. So there's three types of delirium that present differently based on psychomotor, cognitive and motor activity. There's hyperactive, hypoactive, and mixed. Next slide, please. And these are a few slides that I borrowed from my colleagues when I was at UCSF. This one speaks to hyperactive delirium. These are the individuals that have overactive motor and cognitive function. And so you might see them experiencing delusions, hallucinations, thinks something's crawling on their skin or there's bugs on the wall. They're restless, they're fidgeting, they're pulling at things, maybe hypervigilant, quite paranoid, having some agitation. These are the ones that I typically will get geropsych consults for because they present, again, management problems, but it's our job to figure out what it is that's creating this acute change. Next slide, please. And on the flip side is the hypoactive. So these individuals have underactive motor and cognitive function and may look like they have some depression, like Mrs. Jones. Some characteristics include lethargy, excessive daytime sleepiness, slow response times, apathy, decreased responsiveness, flat affect. These are the individuals who might be falling asleep during the middle of physical therapy, falling asleep during meals, just aren't as perky, quote unquote, as they might have once been. Next slide, please. And then there's the mixed characterization. People can exhibit characteristics of both hyper and hypoactive delirium across the day. So more restless and agitated at night and more sleepy during the day. And I don't know if there was a comment in the, yes, thank you very much, Megan, for putting those articles in there. Okay, so let's move to the Zoom chat. Next slide, please. So true or false, most delirium presents as hyperactive. So we have a true. Anyone else want to? Oh, we got a 50-50 almost. Okay. Next slide, please. It's actually false. So while most providers associate delirium with the hyperactive presentation because they present quote unquote behavioral problems, only 25% of delirium cases are actually hyperactive. Most cases are hypoactive or mixed. And as I mentioned, hypoactive delirium is associated with the highest mortality rate and the higher rates of pressure ulcers and hospital-acquired infections. And why do you think that might be? These are the individuals that don't present management issues. They're sleeping. And I say management issues in a very clinical, obnoxious way, because that's oftentimes what gets put on the radar of staff if it's, making it difficult for them to get their jobs done in a very, medical fashion. And I remember talking with a lot of ICU nurses, and they're like, "Oh, we like the hypoactive delirium because they're not moving or doing anything." But those are the folks that are really at highest risk because they have a sepsis or some other medical issue that's kind of brewing, but we're not recognizing it. Next slide, please. So there's many, many different factors or predictors of delirium. And as you can imagine, looking at all of those, many of our folks that we work with in our communities have dehydration, urinary retention, constipation, sensory or functional impairment. But click, please. The primary predictors in the nursing home setting are dementia, infection, anticholinergic medications, pain, depression, and urinary incontinence. Next slide, please. And here's just one instrument that has become, the 3D CAM used to be, or the CAM, the confusion assessment method, used to be the gold standard. And this is one that just kind of has increased the sensitivity and specificity in which the provider asks the patient's questions, records observations, corroborates with the family. Again, understanding a person's baseline is really, really important to determine if this is an acute change or slow progressive change. And then you compare it to the other assessments. And I put the tool there for you for your reference. And a positive score is achieved if one item in section 1 and 2 are positive, along with items in either 3 or 4. Next slide, please. And I borrowed this slide from Dr. Jurovich because I love the picture of the guy in the mask because our behavioral expressions with masks can really impact a person who is struggling with dementia and delirium in particular. So, obviously delirium management, you got to treat the underlying cause, got to go with the flow, be present in their reality, help provide the reassurance, and have a positive tone and facial expression. We call it smizing, has become very popular with our masks. Next slide, please. And I found this from a project in New Zealand called Think Pinches Me Kindly. And go ahead and hit there. So 1/3 to 1/2 of delirium, a person's experiencing delirium can be prevented by addressing these risk factors. So pinches me is pain, infection, nutrition, constipation, hydration, exercise, sleep, medication, and environment. So again, pain, in particular in long-term care, is horribly under-recognized and treated. And oftentimes persons with who are struggling with dementia have PRN pain medicine orders, but don't have the ability to request that pain medicine order. So sometimes getting round the clock Tylenol can certainly help minimize a lot of what behavioral expressions you might see during care in particular. Again, if you suspect an infection, spot it, stop it. Of course, be mindful of your antimicrobial stewardship. Push the fluids, fiber. I love remember fluid, fiber, and footwork for managing nutrition and constipation. Keeping folks walking and engaged. I love the sleep. Don't get delirious. Sleep is serious. And medication, and that's going to be another M that we're going to talk about next week, I believe. So don't prescribe delirium. Be very mindful if there's medications that are on the Beers criteria or what have you that really should not be prescribed. And then environment, be house proud, help, orient, use sensory aids, and engage. And again, be calm, patient, and mindful of emotional needs. Next slide, please. And lastly, the last D of the 3 Ds is depression. And I like to refer to this as down in the dumps. Click. And I can't emphasize enough that depression is not a normal part of aging. Next slide, please. And if I need to drill it home even further, again, we can justify all we want that, wow, I would be depressed too if I had just had a stroke and I had to move out of my house and, my husband had just died. But understanding what a normal grief response is versus subsyndromal depression versus major depression is really important. And I think sometimes the older adults that with whom we work suffer unnecessarily because we have rationalized away their symptoms and not necessarily recognized that they may be struggling with clinically significant depression. Next slide, please. Because depression is the #1 under-recognized, underdiagnosed, and undertreated condition in older adults. And up to 30% of individuals with Alzheimer's will develop a major depression. Next slide, please. So what does it look like? There's, of course, the depressed mood. There could be tearfulness, increased irritability, anger, verbal agitation, loss of interest. Individuals who used to be going to activities are no longer going to activities. Feelings of guilt or worthlessness, if they feel like a burden to their family, changes in their sleep patterns. Typically, it's early morning awakening, so they have difficulties falling asleep, and then they might wake up earlier than they want to and can't go back to sleep. Lack of energy, changes in appetite. Oftentimes, depression in older adults is more characterized by weight loss and poor appetite. Also feeling either agitated or slowed down, difficulty thinking and concentrating, and of course, suicidal thoughts. Next slide. But I think it's also important to recognize that depression in older adults with dementia may manifest in atypical ways. So this could be new onset agitation. And again, it's not an agitation where over the last 3 days, Mr. Jones has been more agitated. It's like, over the last few weeks, Mrs. Jones doesn't seem herself. She seems a little bit more agitated. I wonder what's going on. Or they might be wandering more. They might be more apathetic. They're crying out. More sleep issues, a change in functional status. Someone who was previously able to help with bathing and dressing and grooming is now not able to do that. And also sexually inappropriate behavior can definitely be a sign of an atypical presentation of depression in older adults with dementia. Next slide, please. And I put this mnemonic here because I think it's really important to assess suicide risk in older adults. And older white males are at the highest risk. And if they've had a previous episode of depression, certainly places their risk of suicide greater. And of course, previous suicide attempts, not only in their own lives, but in their family lives. If there's been a history of suicide in the family, that oftentimes kind of creates this, it's a family sanctioned way of coping with the depression in an odd way of thinking about it. But there have definitely been studies to demonstrate that family history of suicide can increase one's own risk of suicide. Of course, ethanol abuse impacts your rational thinking. If the person has had early stages of dementia, rational thinking loss, and social isolation. We really wanted to kind of underscore that one because that has been such a major issue during the pandemic. and has, exponentially increased rates of depression in older adults. If they have an organized plan to commit suicide, so it's not just, do you feel that you're better off dead if you thought of killing yourself, but do you have a plan? Do you have an intent? If someone has an organized plan, that's a definite increased risk that they could actually complete it. And of course, if they don't have a spouse or if they're dealing with a lot of significant illness, certainly increases their suicide risk. Next slide, please. And so for depression screening, the PHQ-9 is already done, but sometimes the initial 2 questions of the PHQ-9 can just be used for a simple screening in between perhaps the MDS mandated PHQ-9 assessments. But serial administrations can be used to reliably assess response to treatment. Next slide, please. And here's just a nice grid kind of helping to delineate a PHQ-9 score and how that rate translates to depression severity and what a potential response could be. And certainly if they're in the 10 to 14 range, they meet the criteria for major depressive disorder and should be started on an antidepressant. Next slide, please. So just revisiting Mrs. Jones. I know there was folks that thought that she might need depression. And as you look here, she seemed withdrawn. She's spending most of her time in bed sleeping. She's not participating in activities. She's had weight loss. But the fact that she's falling asleep during meals is probably what's contributing to her weight loss. And that's not a normal part of the dementia characterization, if you will. And the fact that there's been this kind of sudden change. She's up at night for the last 3 nights. She's restless and she's impulsively wanting to get out of bed without assistance. And of course, her recent hospitalization, increases her risk for delirium because they've probably just pulled out a Foley catheter. Who knows if she has a UTI? Her oxygen status could certainly be problematic if she's just had pneumonia. And she certainly spent 2 days in the ICU. So that's increased her risk for delirium. So again, just wanted to kind of highlight some of those key factors that came out. And of course, the fact that she had underlying mild to moderate dementia, again, jacked up her risk. Next slide, please. So take-home messages. I think it's the take-home messages that I want you to really hone in on are understanding an individual's specific cognitive challenges and remaining abilities is essential to supporting person-centered care and what matters. And the 3 Ds of aging often overlap, and more than one illness can be present in an older adult at the same time. So in the case of Mrs. Jones, first you want to tackle that delirium, rule out delirium, any potential reversible causes. And then after you've done that, then you want to screen for depression. Become familiar with standardized tests and use them to support your diagnosis and guide care. And I think recognition of the risk factors and routine screening for delirium should be part of comprehensive nursing care for older adults. And this is what the whole team can participate in this. And I think is really important. And I know when I'm working in different nursing homes and talking, I'll go into the room and the CNA might be there and I say, so what's going on with, Mr. Jack here? And, the CNA will say, well, I'm just the CNA, you need to talk with the nurse. And I said, no, you're the front line. You're our eyes and ears. You're our most valuable player. Please tell me what you see. And again, empowering our staff that this isn't just, dietary have been invaluable in helping us figure out that there's a change in status. So again, really mobilize the whole team. And effective interventions target the underlying cause and maximize physical, psychological, environmental support. Okay, let's end with our post-test. So what are the goals of addressing mind and mentation? Support cognitive functioning, maximize independence and dignity, ensure everyone is prescribed a cognitive enhancing drug like Aricept, identify and treat the 3 Ds, prevent the 3 Ds, or all of the above. Once we have a good showing on the Zoom poll, I'd love to see where we stand. Megan, thanks for putting all the links in the chat. What's our response?
Are you not able to see that?
No, I'm not able to see it. I just still see the question.
Are you seeing it now?
Yes, the correct, yes. But I don't see how many people, I don't see the overall response.
Like the, oh, okay. So we have 39% with cognitive functioning. We have 35 with independence and dignity, 6 with cognitive enhancing drug, 65 with identify and treat, 23 with prevent the 3Ds, and 29 with all of the above.
Okay, and so if you can click on the next slide. So it's early identification of mentation problems, effectively treat and manage depression, and prevent the 3Ds. So even though sometimes, you know, Aricept and cognitive enhancing drugs have been, you know, prescribed like candy, it's not necessarily something that is very beneficial in many respects. So we want to prevent, identify early, and effectively treat and manage. Next slide. And I just like to end again on a positive note, strengths-based approach that wrinkles should merely indicate where smiles have been. Next slide. And thank you. I really appreciate working with all of you. Please let me know if you have any questions.
Thank you so much, Caroline, and amazing job sticking right at time. My gosh, you are a pro. Are there any quick questions for Caroline? And you can continue to ask those wonderful information. All right. I don't see anything popping in really quickly, so we will move on to our QAPI portion of today's presentation. Adrienne Butterwick and Jean Lyon are here. They're going to talk to us about prioritizing quality opportunities and charter PIPs. Welcome, Adrienne and Jean.
Hi, Catherine. Thanks. And thank you, everybody, for joining us today. We're here to talk about step 9. I have my partner, Jean Lyon, with me as well, and we are happy to be back with the folks here today. So next slide, please. So at the end of last week's session, you were asked to identify a new improvement opportunity. So we would love to hear if you please share with us if you've identified any new gaps or opportunities for a PIP, anything that you may have conducted over the past week. We would love to hear how that has gone and any insights you maybe have gained. So please go ahead and put that in chat or feel free to unmute. We do have a couple minutes if anybody would like to share anything they've been working on over the past week. All right. Well, moving forward, as I said, today we are talking about step 9, so prioritizing quality improvement opportunities and chartering performance improvement projects. Next slide, please. And next slide. Let's go ahead and get started with our pre-presentation poll here. So, which of the following clearly establishes a project's charter? Goals and scope, timing and milestones, team roles and responsibilities, or all of the above? Go ahead and answer that as we go forward, and we will revisit this answer at the end of our presentation today. So now I'm going to turn the time over to Jean Lyon to get us started talking about QAPI prioritization.
Oh, thank you, Adrienne. And again, an excellent presentation by Caroline, and I do appreciate that on dementia. And I was thinking during delirium during the presentation that given the number of misdiagnoses of people with delirium, I was wondering if that wouldn't make a good QAPI project. But what we're going to do now is just talk about prioritizing opportunities for improvement as a key step in the process of translating data into action. Next slide. And prioritization, we included a worksheet here that you are free to download. The link is in chat right now. And the categories include prevalence. In other words, how often is an issue occurring? The risk, what is the level of risk posed to the resident? The cost, what is the cost incurred each time this issue occurs? The relevance, how relevant is it to the individual, to the residents, to the facility, to the organization. And Caroline says she's very happy to work with anyone who wants to work on that PIP with delirium, because obviously that is a very prevalent. There's a risk, increased cost, relevance, responsiveness, feasibility, and continuity. So fits perfectly into doing a PIP using something like this QAPI worksheet. Let's go to the next slide. Additional factors to take into account. You want to ask things like, what existing standards or guidelines are available to provide direction for this initiative? What measures can be used to monitor the progress? Is the topic publicly reported on Nursing Home Compare? Which type of changes primarily will be involved? Is it going to be system changes, environmental changes, staffing changes? In the case of a PIP for delirium, it might be educational changes, knowledge-based changes in the staff and providers to be able to identify those signs of delirium that are so important, because like Caroline said, individuals with delirium have a much higher risk of dying because of that. Which staff will be most affected by the initiative? What training needs will this initiative present? And is there an identified champion or champions for this initiative? These are the main difference between the charter, between a charter and a work plan, is that the work plan is the detailed list of actionable steps that need to be taken in order to accomplish given milestones. Other key elements that you need to consider, make sure you allow for tracking of barriers. Forethought should be approved with a signature by leadership, so you get buy-in from your leadership and other project team members, such as your administrator. Without that approval, you're destined to go nowhere. Recommended timetable for the full project, including all phases. Okay, now I'm going to turn it back to my colleague, Adrian.
Thanks, Jean. So now that we've talked about factors to consider for prioritizing your PIPs, the next step is really chartering out your PIP. So once you've identified a PIP that you would like to focus on that has risen to the top of your priorities, the next step is really putting that PIP into a charter. So a project charter clearly establishes the goals, scope, timing, milestones, and team roles and responsibilities. It's developed by the QAPI team and then shared with the team designated to carry out the PIP. So sometimes this can be a separate team, and sometimes this is a member of that team that then carries this on to work in a more dedicated fashion with your PIP team. The charter really helps your team stay focused, but it's not specifically a work plan, as Jean mentioned, and sometimes that can get a little bit unclear. So we just want to make sure to reiterate that this is really the overarching mapping out of goals and kind of team alignment. And then where the actual work takes place, I think we'll be talking about that at step 10 next week on really how do you document your PIPs and how do you move progress forward when you are actually doing your performance improvement projects and all the effort that that entails. Next slide, please. So we were hoping to be able to have a partner with us to share their experience about a charter, but we did want to just give a few more tips and tricks about using charters for your performance improvement work here. So you want to really focus on problems or issues that you consider important. The priorities that Jean went through are kind of a standard list, a nice set from our QAPI at a glance toolkit that we're all very familiar with. But sometimes there are other priorities that maybe tie more closely with your organization's goals and mission. And sometimes you can even add other categories to your priorities to make sure that you're actually addressing and weighting those appropriately. So for instance, maybe you're looking specifically at getting more resiliency infused within the work that you're doing. And how can you attach a rating for resiliency into some of your PIPs that you're prioritizing? And how does that come into play with your priorities? Infection control is another really common category. Sometimes those can be prioritized at a higher level, depending on some of the other factors that Jean went through, risk to our individuals living in our nursing homes, things like that. And then the age-friendly framework. We always want to make sure that everything that we're doing with our quality improvement work ties back to the age-friendly framework. And there are ways to include that in your prioritization as well. And, we've even seen people tying their performance improvement projects directly to their organization's goals and missions around different things that you may not immediately intuitively affiliate with the work that we do, such as vaccines and things like that, and ensuring that we are keeping all of our residents safe and healthy in our nursing home. And some of the work that comes into play with that is vaccines and boosters and things like that. So all this is just to say that we are sharing these tools with you, but you really have the freedom and liberty to take this and customize it to what works directly with your organization, what fits best with your team and the residents that you serve in your buildings. So we just another, we use the word charter on purpose. A PIP is a lot more than really just a casual effort. It entails a specific written mission to look into a problem area. Your team includes people in a position all across the different areas of your organization. And we've talked about this in some previous sessions as well, about ensuring that you have representation, from people who are directly in a position to explore that problem, such as, direct caregivers, nursing assistants. And, sometimes if you're looking at a specific issue or problem that involves a process, that the individuals who are affiliated with that process are also a part of your PIP team. And so maybe dietary, things like that, thinking outside of just your kind of standard staff that you use in your more day-to-day work. Chartering really implies that your team has been entrusted with this mission. As I said, there needs to be a process to report back on progress, and there are a lot of tools and tracking worksheets for that as well. And really, the development of a charter helps add strength and importance and an element of formality to your PIP process. The team typically has a leader, and it can be a really nice experience for staff development, for cross-functional training, and for just a more cohesive approach to our quality improvement work. And as I said, your work plan and other areas kind of carry out the actions, but this is really where we're going to propose our timeline, and then any other items that we want to make sure that we have clear in our charter, such as potentially budget or other confounding factors as well. So before we revisit our post question, I just wanted to take a minute and open it up to the folks here. Does anybody have anything to share as far as using charters or thoughts or ideas on different ways or categories that you use in your nursing home to prioritize performance improvement projects? And then I can check into the chat here as well, but yeah, just would welcome anybody's input as we have a few minutes for discussion here before we turn it back to Carmen for our culture. I'm just going to scan through the chat, but please feel free to unmute and share with us as well. So yeah, I do think an excellent performance improvement project would really be looking at the misdiagnoses of delirium. I think that's a really interesting idea to pursue, and maybe that's something we can continue to work on if anybody is interested. I know Dr. Stevens just offered her support in that area, so if anybody is interested, we'd be happy to work with you. And it looks like Jane has shared COVID rising cases PIPs idea back to basics. So evaluating appropriate PPE use and hand washing with the goal of establishing a baseline question and percentage improvement. All right, interesting. Jane, do you want to share a little bit more about that thought?
Well, Don Dr. Jurovich just had posted in the chat earlier about rising cases in North Dakota and what would be an appropriate project. And that's what occurred to me, is that it's kind of boring, repetitive, but to get back to basics. So I'd be open, very much like to hear you experts possibly describe how that might be approached.
Can I share something, everyone, on that? Thank you, Jane. I read a book called Influencer, and it challenged us to think about, like, are we asking the right questions? So rather than, let's say, counting how many times someone washed their hands, here's a different question, are we comfortable pointing out that the doctor didn't wash their hands? We have some doctors on the line, but notice the idea of elevating what we measure or observe or watch for. Like you just said, it's kind of boring. How do we elevate it to get at real issues? And then teams that actually focused on that just started to say out loud, we're all held accountable, and you feel free to ask me if I wash my hands. You know, the director of nursing, the administrator, the nurses, you know, even the infection control preventionists, right? The infection preventionists. So rather than assume, building a culture that it's okay to ask each other. Isn't that interesting?
I apologize. I think I'm having some internet issues. I think I've been freezing a little bit here and there, but absolutely, Carmen, you know, the culture of safety is really what we're talking about when we're talking about having that environment where you can you know, share those insights with people in a more, you know, let's all succeed together, right, type of mentality. So this definitely plays a big role in everything we do.
So this is Dr. Jurovich. I would echo Dr. Winston's comment or call to arms here to think about using the charter. So Megan McClure put in the chat box the worksheet. So if you have not used that worksheet before, maybe it'd be good to copy that link and to you know, work with that to create a PIP related to the you know, protective equipment, hygiene, and other procedures that you might want to look at for mitigating spread of COVID. You know, it's just like the Yogi Berra thing, right? He says deja vu all over again. So, you know, if we can do a PIP and hop on this quickly, we can start addressing the variant. And then also maybe looking at your policy for prescribing the anti-COVID medications, right? You've seen that those are coming out now as free medications, you know, through the federal government. So, you know, what is your policy? How remember from the last time, you know, we had a 5-day window to you know, apply these medications. And so you could even do a PIP on the pharmacist as to, you know, what the protocol is for prescribing the medication if somebody screens positive.
Adrian, did you want me to share the results of the QAPI poll, or are we just moving on?
Yeah, please do. I apologize. My internet is just freezing here. So I also missed some of what Jane shared when she unmuted. So I apologize for being a very poor facilitator here at the very end of our presentation today. My internet is just not cooperating. But revisiting our poll from the beginning of our session today, it is all of the above. These are elements that are in a successful and you know, clear, effective project charter. And just keeping in mind that this is really kind of the tip of the iceberg and starting your actual work plan. And now I will turn it back over to Carmen to wrap us up today. And I do apologize for my technical issues I've had.
And we understand, Adrian. Oh, sorry.
No, I was going to say the same thing. That's okay. God knows we've all been there.
Exactly. Okay. So everyone, an arena we've learned about language from is really the disability community, and I might be saying it wrong myself, but even in the 80s, they were talking about something called person first language or people first language. So just a nice reminder, or if you've never heard this before, it's the idea of putting the person first always, before a diagnosis, before a disability. So look at this word, diabetic. We all use it. It's very common. You might think, what's wrong with diabetic? We all use it. But notice it's actually a label. And so what would be the opposite? It'd be the person first. So this is so-and-so, and they have diabetes. And then here's a funny example on the flip side. How many of you wear glasses? We could look, aha, I see a few. And that, notice how I said it, we say we wear glasses, when in fact, what you really would be, I guess, would be myopic, right? So I just think that's funny that we say it in some scenarios and we don't in others. So let's follow the lead. Next slide, please, on just putting the person first. This is Linda, and she happens to wear glasses. People are not a disease causing a problem, but they're human beings with needs, right? And require help. So a paraplegic becomes, the language becomes, that's so-and-so who has paraplegia, that's so-and-so who has dementia. So it's really considered old language now. What most people don't refer to suffers with dementia. And I myself am moving away from living with dementia, because we don't say living with depression very often, living with high blood pressure, maybe sometimes, but we tend to just say they have this or that. Next slide, please. And then how do you like this, everyone? So what do you prefer to be called? Handicapped, disabled, or physically challenged? Joe would be fine. This is the most appropriate label. The most appropriate label, I think it usually, sorry, goes on to say, is usually the one people's parents have given them. And so I like calling it the only one, the only label needed ever. I'll challenge each of you to maybe move in that direction, and I'll challenge myself too. And next slide, please. Other labels, some of you mentioned the screamer. Oh my God, goodness, I've heard them all. The wetter, the isolator, the hoarder, the wanderer, the frequent faller. Some frequent fallers get called the repeat offender. We certainly hear the complainer, the difficult resident, the difficult family member. Please, everyone, we don't have to say these ever again. The diagnoses become labels, the quad, the CVA. Sadly, in an institution, sometimes all things like this become labels. Certain shifts are supposed to get up people, so they start to be called the get-ups. And certain shifts are supposed to put people down, and you could be the get-up and the put down, everyone. And thankfully, we're changing culture where we don't decide, we don't make people get up, we don't make them go to bed. We change our cultures and our systems to support people and what they need today. Did they sleep well last night or not? We don't wake them. We honor natural awakening. Some of you brought up room 202, the bed number. Isn't it interesting? The title memory care actually violates HIPAA. I think that's kind of funny. You know, HIPAA is such a big deal, and yet notice it happens. So with that, that'll be it for today. The next slide is just simply a running summary of words we've just looked at. So thank you.